now move on to our next presentation by Dr. Bum-Soo Kim from Seoul, South Korea, and he will be presenting intracranial and extracranial MRA.
Thank you, Chairman. I'm Bum-Soo Kim from Seoul, Korea, and thank you for giving me a chance to give a lecture, educational talk regarding neurovascular MRA and geography. I packed my talk with the basic sequences, including TOF MRA and geography and the contrast enhanced MRA and geography, in the evaluation of ischemic stroke and aneurysm and briefly arteriovenous shunt. So the TOF time of flight MRA and geography is mostly widely used to sequence in the evaluation of neurovascular disease because it has no contrast media and to get a relatively high resolution image. But the problem was the long imaging time. I mean, let's say on the left side, this imaging sequence was our protocol until 4 years ago. To get this kind of image, more than 7 minutes was used to get about 0.5 millimeter voxel size. But since 3 years ago, the compressed sensing has been included in the clinical routine. I believe that TOF MRA and geography was the first clinical protocol with, protocol utilizing the compressed sensing. And so since 3 years ago, our protocol has been changed to get this kind of intracranial TOF MRA and geography with sense factor of 4.5 to get an 0.0 milli isovoxel size less than 4 minutes. And for the neck, less than 3 minutes to get similar metric size for the neck. Most recently, our team has been involved in the making good utilization of the deep learning to make an denoising and super resolution reconstruction. So as a clinical neuroradiologist, I was involved in the pilot evaluation of the TOF MRA and geography in utilization of deep learning. And this is a very first case I was during the pilot evaluation, and my gut feeling of this is the background noise has been quite reduced, and it made kind of distal vessel visibility is improved. But still, let's say in this patient, the stent-related artifact of this particular stent, a patient with aneurysm after stent-assisted coiling, it has not been improved actually. But I hope this kind of algorithms can have a good utilization in the near future. Back to the clinical utilization, TOF MRA and geography, although it is quite frequently used, we do have a kind of pitfall from the artifacts, including flow saturation, or complex and slow flow, or recirculation artifact. As an example, here the giant aneurysm is not clearly visualized because of the saturation artifact, as well as the distal vessel, distal artery as well, for the giant aneurysm. And sometimes we do see that the degree and length of the stenotic lesion is overestimated because of the saturation artifact compared to the DSA here. And sometimes we have the recirculation artifact and the posterior aspect of the carotid valve that can simulate stenosis by the recirculation artifact without any, the real stenosis here. And to get an arteriograph, we kill the venous flow from the opposite side, but sometimes we do have artery from the above to the cardiac direction. So in case the downward flow can be killed because of the saturation pulse to kill the venous pressure. So the segmental artifact with the simulating the stenosis or something can be made from this saturation artifact. On the contrary, contrast enhanced MRA and geography, mostly for the faster or wide FOV imaging acquisition, it too has a less frequent artifact compared to the TOF MRA and geography. I will talk later. And as a clinical utilization, we do it mostly with a follow-up imaging after treatment of this neurovascular disease, and also evaluation of the neck. So on the contrary, as I have told, let's say saturation artifact at severe stenosis is less frequent with the contrast-enhanced MRA angiography, and also saturation artifact from the giant aneurysm, the contrast-enhanced MRA angiography erases that. And on the right side, the image of the TOF of the brain and the neck, there is non-visualization of the vertebral artery, but it is visualized on contrast-enhanced MRA angiography. So it is a kind of, it is another, I don't think it's advantage or drawback, but we have to compare the TOF and the contrast-enhanced MRA angiography to that, interpret this one. So this is a patent, sorry, where is my patent left vertebral artery, but with a downward blood flow, as there is an occlusion of the subclavian artery, that so-called subclavian steel syndrome in here. But it can be much more easily recognized with a time-resolved MRA angiography later on, something like this. So time-resolved contrast-enhanced MRA angiography can give a dynamic evaluation of the vascular disease, including the arteriovenous shunt, as well as collateral imaging in a patient with acute ischemic stroke. Something like here, with already passed on arterial phase, but this particular patient had an occlusion of the right side MCA with increased leptomeningeal contrast, collateral flow here. But for the technical aspect to acquiring the contrast enhancement, we should inject, you should not inject contrast media on the left side, because there is the patient with contrast media not goes direct to the heart, but goes refluxed into left internal jugular vein and then to the right side to get to the cardiac. Actually, our experience from evaluation of more than 3,000 patients, about 1.6% is not a small number, have an retrograde venous reflux on the left side of the normal non-symptomatic patients. So it is not a small number. So to get a contrast-enhanced MRA angiography, and also other dynamic contrast enhancement study as well, it is better to inject the contrast media on the right side. For the time-resolved MRA angiography, you have experienced that low dose injection of the contrast media is quite acceptable to get reasonable image quality, down to just 30% of the injected contrast media to get time-resolved MRI angiography in our protocol. So at the moment, our protocol to get a neurovascular MRI angiography in our hospital, the non-enhanced MRI angiography, including TOF and the neck and brain, is mostly for the screening of the neurovascular disease. And for the high-risk patient of atherosclerosis or follow-up, longitudinal follow-up of the disease, we do the TOF neck followed by combined the acquisition of multiphasic low dose followed by high-resolution single phase with a divided injection of the contrast media. And for the neurovascular disease, after follow-up, we do intracranial. And for the spinal, we do spinal angiography just before doing the spinal angiography or on follow-up. So for that, the injection of a contrast media is divided, or 30% and 70% for the multiphasic and single phase to get an injection. So injection of the contrast media is not increasing in amount actually, except for the spinal. For which about 50% we inject more. Let's back to the clinical application. For the ischemic stroke, role of the imaging in ischemic stroke is, exclude hemorrhage and exclude other causes of stroke, and estimate the volume and location of the infarcted tissue and tissue at risk, and find the occluded artery to have the treatment planning. The MRI angiography can give this one. But nowadays, in most institutes, for the acute ischemic stroke evaluation, the CT, CTA, and CTP is mostly backbone, because rapid availability, let's say in our hospital, CT is integrated in the ER emergency room. So we also do the CT-based triage. But still DWI is highly sensitive for the detection of infarction, so it can have an potential, I believe. So at the moment, CTA, including three-phase CT angiography, suggested from the category group, is quite most widely used for the evaluation and estimating outcome of the acute ischemic stroke. And recently, perfusion, evaluation of the perfusion with operationally defined threshold has been integrated in several protocols, including dawn and diffuse, that made extension of time window for the arterial thrombectomy after onset of the symptom up to the 24 hours and 6 hours, mostly with the rapid software here, but mostly CT-based, right? But we can make a collateral imaging from the MR angiography as well, I believe. And our team also had to try to put some kind of utilization of the low dose time resolved MR angiography to get the perfusion collateral imaging. But it was quite good correlation with the perfusion image, but it is still in progress because it takes a time with an offline generation of this process. But another Dr. Hyun-Jung Kim from our team has a very good effort to make a good utilization of the time resolved MR angiography to get a collateral map. And he made in cooperation of the Korean PhD in Siemens Korea, they made a very nice post-processing of the TSC as well as time resolved MR angiography to get a collateral imaging system. And they compared the collateral map from MRA and the collateral map from the MRP. There was a good correlation, and even they applied this one and the prospective patient to see the proposed MR-based collateral score was quite valuable in estimating a good outcome after thrombectomy of acute ischemic stroke. And even recently, they applied it to the estimating the infarction growth size, growth of the size was good from the ratio of the capillary phase defect divided by early venous phase defect. Anyhow, this is in now ongoing generation making, development of the processing software from this Hyun-Jung, Dr. Kim, and she told me, she asked me that if there is anyone who is interested, call her by mail, contact her. So for the acute ischemic stroke, MR angiography again given not only about the morphology image, but for the parametric collateral imaging from the multiphasic MR angiography. For the intracranial aneurysm, which makes a subarachnoid hemorrhage, for MR angiography has been quite a good imaging tool for the follow-up after treatment. Because intracranial aneurysm is multimodal, can have a multiplicity. This is the largest number of the aneurysm which we have to treatment in our group. And but from the diagnosis, MR angiography has a good ability to diagnose the intracranial aneurysm. But traditionally, it has been thought for the small aneurysm, MR angiography was inferior. But if you do use the higher Tesla with reconstruction with the volume rendered image as well, the detection of a small aneurysm can be increased. For the follow-up after treatment to aneurysm, traditionally it has been with the surgical clipping and the vascular coiling. But here, the aneurysm coil makes a very bad susceptibility artifact, and the coil gives some very bad metallic artifact on CT angiography. So the mostly the routine follow-up after surgical clipping should be CT angiography, and endovascular coiling, the MRA is proposed follow-up modality so far. And there is coupling the contrast enhanced TOF MRI angiography can give an increased sensitivity and the specificity to get to diagnosis recurrent recanalization of the aneurysm. But as a clinician, stent-assisted coiling, after stent-assisted coiling, we frequently see an image like this. There is a decreased signal in the stented segment, but as a clinician, I always see if there is any bright signal intensity outside the stent, it can make a suggestion that aneurysm recanalization outside the stent. Anyhow, if you see thoroughly with the reconstruction with the multiplanar or narrow volume reconstruction, and even we can evaluate in the stented segment as well.
And then if you could summarize for us.
I will, and I mean, but still there is an other materials developed like an flow diverter or flow disruptor. So it has an susceptibility portion at the detached zone as well. So we need more the other sequences, including ultra-short ASL-based MRA angiography, including silent or PETRA MRA, has been effective for the stent-assisted or flow diversion or surgical clipping, as seen in here. So maybe I will skip the basics of the brain TOF, brain AVM and dural AVM, but TOF MRA angiography has a pitfall that we can evaluate upward feeding artery or nidus, but it is quite difficult to thoroughly evaluate the downward flowing draining veins from the TOF MRA angiography, but it can be augmented, I mean, by utilization of the contrast enhanced MRA angiography as seen in here. And for the post-processing of multiphasic MRA angiography to get an arterial or venous separation, so you can get a very easy lookout of the vascular malformation or shunt, like here, this is an arteriovenous shunt, or this is a venous malformation, not an arteriovenous shunt here. So summing up of my talk, I just packed the basic techniques, including TOF and the contrast enhanced MRA angiography in the utilization of neurovascular disease. But recently, ultra-short ASL-based MRA can be used after the treatment of the vascular disease with the metal inside. But more recently, we put the vessel wall imaging to mostly for, in our cases, mostly for the differentiation of atherosclerotic disease or dissection or vasculitis, including moya at the moment. But these algorithms, I mean, sequences will be a good armories for the clinical evaluation of neurovascular disease. So we do have a large toolbox of different techniques, and examination should be tailored to clinical questions to combine different techniques. And thank you for your kind attention.
Thank you very much for your extensive experience in neuroimaging and how all the techniques developed here in the MRA have been used in your routine clinical evaluation and where it falls in with CTA. So thank you very much, and I'll hand the moderator session over.